Ed here, and we're doing Ed Talks. This one a little different, and I just want to ask everyone to sort of brace yourself a little bit, open your hearts, and really talk about a heavy topic. Normally our topics are meaty, but not heavy, and this one comes with a burden, and also with an awareness, raising awareness of a really important issue in healthcare that we kind of bury under the carpet. No one really talks about it much, but that's going to change. And one of the ways it's changing is by addressing it on Ed Talks. So I want to introduce to you a friend of mine, good friend of mine, Gregg Masters. So Gregg, welcome to Ed Talks.
Thanks, Ed. Pleasure to be with you.
We'll get into your background a little bit, but first, I always like to try to share, like, hey, how do I know Gregg? So Gregg and I, well, we've both been around a little while in healthcare, and we've interacted. I think it started on Twitter. We didn't ever talk about this, but I think our relationship sort of started on Twitter, and so we've known each other. I want to say 10 years, 10 plus years. Going back in a lot of different venues, and I've always admired you from afar. We've had a couple occasions to get a little bit more close. And I wanted to welcome you to share your story with us here, and take an opportunity to help raise awareness about this particular issue. But before we get there, Gregg, why don't you tell us a little bit about yourself and your journey in healthcare and what you do today? Because I love the content. You put out tons of content. You can see that there on your background. And I'd love for you to share with our audience what that is.
Well, thanks again for the opportunity. And yes, we actually the origins of our relationship actually is nested inside social media, Twitter specifically. I think the original connection that I had with you after seeing your involvement on Twitter was your tenure at Texas Health Resources, and I think he came after Dave Muntz, I
Yeah,
believe, if I'm
that's right.
yeah,
Yeah.
if I'm not mistaken. And I was charged with forming a super PHO at Texas Health Resources, and that was while it was in the formation days between the integration of Harris Methodist Hospital, including Harris Methodist Health Plan, and then Presbyterian Healthcare. I believe it was Arlington Memorial was the
Yeah.
third.
Yeah.
Once upon a time, Baylor was at the table. Anyway, that
Yeah.
forged Texas Health Resource. I went, CIO at Texas Health. I'm going to follow him. And then I started noticing, and back then it was high tech, meaningful use, and interoperability. And the theme of the year that HIMSS would spin off in terms of solutions that these promising IT platforms held out for health systems, physician enterprises, and such. So I noticed you started following you. I'd retweet your stuff, ping you back and forth, and then I guess we got a little closer and tighter, met at a few meetings. We talked on Health Unabashed not too long ago with my colleague, Gil Bash, and we're all part of this army trying to see transformation in a legacy siloed system that is change resistant. So I think we're soldiers in that army.
Yeah, definitely. Yeah. And the work you did for us, Texas Health, that was very meaningful. We all ultimately came together, ended up retiring the health plan just because it conflicted so much with what the hospital was doing and the clinicians.
Right.
Um, but
And
yeah.
there's a whole story behind that one because that ties directly to Optum and the interesting the work I did for Pacific Care, which acquired Harris Methodist Health Plan, was benchmark pricing as an IPA model HMO operating in a metropolitan marketplace. They benchmarked it to that study, and I think a year later they acquired the health plan.
Yeah. Yeah, it's super, super interesting. And it was very helpful, I think, for ultimately for our community. So yeah, so we're kindred spirits and trying to do the right things in healthcare and help accelerate transformation, those sort of things. I started writing this book, as you know, with Chris Ross on patient experience. And so pretty much done with that. It's still some publishing things. But during that end process, I received a text from you. And it was rather alarming text. So do you want to tell us about that? I mean, I even had to take a moment there just to recollect.
Oh, yeah.
But you want to tell us about that and sort of what happened with
Well,
your son, Anthony John Masters?
So the pretext for the text was the fact that when I was doing my due diligence on you, preparing for our interview with Gil on Health Unabashed on Healthcare Now Radio, I happened to notice in your bio, in addition to THR and additional positions you had held previously, you were the CIO at the New York City Health and Hospitals Corporation, which coincidentally operated the hospital where my son was seen in the emergency department and then triaged to an ICU and triaged to a step down unit and re-triaged back to an ICU before he died 7 days after admission. And I decided, gee, I was just making my life pretty much and his experience pretty much public, as I've done for the last since joining Twitter in 2008. I've been living out loud in public, and I've been advocating for health system reform, new business model, how to integrate and align incentives in such a way that hospitals and physicians can cooperate versus compete. And oh, he's served here. I'm having trouble here. I can't seem to reach everybody. I would go through the normal channels of floor nursing to nursing unit manager to supervisor to administrator, and somewhere along the line, hopefully a physician, an attending physician who may be in charge, because my son was in Elmhurst Hospital Center ICU. I received a call June 4th, 7 a.m. from his fiance telling me, Greg, Anthony's in the ICU. And that's about all I heard in that moment. I went numb. But I later learned that he was riding his bicycle home about 1 a.m. He had been with clients or prospects. He's in the alcohol industry, so he's often out late. He was riding his bicycle home, not wearing a helmet, and he collided with a pedestrian. It's not clear whether he veered into the pedestrian or the pedestrian stepped in front of him, and he fell from his bicycle. There were no injuries to the pedestrian, no claims were filed. He fell, hit his head, became unconscious momentarily. EMS was called, probably by a bystander, possibly the person, the pedestrian whom he encountered. EMS scraped him off the ground. He regained consciousness. He was taken to a level 1 trauma center, the ED, associated with Elmhurst Hospital Center, affiliate of New York City Health and Hospitals Corporation. And he was triaged out with a Glasgow score of 13, which measures head trauma. And a 13 score is a mild head trauma. So I was somewhat encouraged to learn when I got there that the nature of his trauma was relatively mild. There's no such thing as unimportant or mild brain trauma, if you will. But on the scale of grading, he was on the mild side. I was told I was there the next morning, took the red eye out. I was in the ICU the next morning, spoke with the chief of service, the ICU director, who was an attending faculty member at the Icahn School of Medicine at Mount Sinai in the hospital, and they staff, if not technically operate, Elmhurst Hospital Center. So I'm having trouble locating accountability, finding someone who's in charge, speaking to an attending physician, or at least a senior resident, possibly a fellow. All I got was telephone access to PAs and floor nurses trying their best, but in the absence of doctor's orders, clueless as to what to do for my son. So I was told by the ICU director, 6 to 7 day length of stay. He may need some therapy after the fact, cognitive, physical speech, whatnot. But for the most part, expect a 6 to 7 day length of stay. On day 3, I can go on. Do you want me to detail the whole start to finish experience for him, or do you want me to pause and you want to talk about it?
Well, I think sort of where we're headed is that you kept running into these same obstacles, right? It's like, and I want to.
Why I reached out to you,
yeah. And so, and I'm not here to blast the health system, but I will tell you, and I won't name names, but I did reach out. Like you sent me that SOS message. I'm like, damn, if that was my kid, someone reached out to me, I'd be wanting my friends to take action on my behalf if they could. So I did, and I reached out to the CEO, and it was a different CEO than I had served. And I mentioned, hey, I used to be there. I used to be, one of you, and um, we helped. We did the whole digital transformation while I was there for New York City Health and Hospitals, um, and it really wasn't much there. But I think the most disappointing one was I reached out to someone who corporate responsible for experience, and they were basically like, well, I'm sorry, but you really need to call that person, that hospital. I thought I was going, to the right level, like getting the right attention. This is like SOS, and they're like, sorry, maybe over there. And that's emblematic, that story right there of exactly what happened over and over and over again with your son. So
Right.
maybe if you pick up, and I purposely have not used the term that you discovered for this phenomena. I thought I'd let you introduce it because I know that you're sort of rallying a lot of forces and bringing this up very publicly so that people are more aware and that we take action so it doesn't happen to another Anthony.
So yes, thank you. So in a prior life, I actually served as senior associate hospital director for a major academic medical center in here in California, Southern California. And I became intimately familiar with academic operating hospitals, the clunky governance nature, the conflicts between hospital administration, the departmental silos of departmental chairs who kind of own the world they live in and don't necessarily collaborate and cooperate. So I know it can be clunky internally. So I decided to exercise the pressure points that I knew existed, and I went up the food chain.
Yeah.
I tried to get attending eyeballs on my son. All I was getting, as I said, was floor nursing doing their best, mostly PAs telephonically engaging. And then after he started, so he was downgraded and transferred from ICU to an intermediate care facility, that an intermediate care unit, telemetry monitored. And on day 6, when he was supposed to be the day before discharge, he started to crash. And that's when I became increasingly concerned. The care I had been observing up to that point prompted me to investigate something called NMP, which stands for Not My Patient, Not My Problem. And this is what I felt I was seeing, because this is a teaching affiliate of an academic, of a world-class medical school, clearly a world-class medical school, teaching affiliate that is staffed by attendings, fellows, residents, PAs, that he would get top quality care and a level 1 trauma center. So they knew trauma. They do trauma 24/7, 365. They're trauma informed, trauma competent. But there was no one in the room who seemed to recognize or take charge for his care. Ergo, the idea of the bystander effect, also known as not my patient, not my problem. The way I see that applied is we have such a hyper specialized and siloed care team structure. Everyone comes in with a very narrow lens as to what's within their competencies as per their specialty, but no one seems to have a 360 or holistic view of what the patient actually needs. So they come together in huddles, they do their briefings, and seemingly, as I observed, no one was in charge. They're all standing around pretty much observing, nurses waiting for directions, and none of the residents, interns, or PAs willing to simply step up and take charge of his care. That caused me some concern. So I authored this post, NMP, Observations from the Bedside. And I was approaching it academically because at that time I hadn't had the outcome of his death experienced yet. It was more about where this train was kind of going off track in terms of team huddles, briefings, care management, so to speak. That's why I reached out to you. And I think the text we got back was, gee, yeah, technically we own and operate the facility, but it's pretty independent. We have little influence over their operations. We suggest you call the general information number and ask for the attending on call. Well, I'd done much more than that. I'd gone to the nursing supervisor of the unit where he was starting to crash. He was having very labored breathing. He couldn't get air as far as I could see, and demanded that the critical care intensivist, attending critical care intensivist, come in the room, diagnose his problems, get him the help that he needs. That didn't happen. The nurse supervisor went to the call list, went down the list. First person called was not on call. The second person called was on call, wasn't attending, but was a neurosurgeon. And the problem, as described, she said, well, it doesn't seem to be a neurosurgical event. I'm off site. It's 10 p.m. I'm not coming in. So that's kind of where it was left. And I believe I went through the food chain as one could reasonably be expected to do, and got the result we got.
Yeah, super, super sorry, clearly. And that's why, we're talking, because we want to raise awareness, because uh, it's not just Anthony, it's many, many others. And we're not going to let this go. We're going to make sure that more people know about it so that we can take action. To me, Gregg, this is just so basic. Like I was trying to think, where did I learn it? I don't know if it was in the military as a young Army officer, but definitely in IT. I was taught by someone, and therefore I propagated this throughout my career. And that is, you own the problem. If someone tells you something, you observe something, you own it. So I don't care if you're a network engineer, if we stick with the IT analogy here, if you're a network engineer and it has to do with the application, and someone said, hey, there's a problem here with EHR, you don't tell them, I'm a network engineer, go take a hike. No, 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 no. You say, I'm really sorry about that. Let me take some action and I'll get back to you. Then you go back and you figure out, oh, there's an application, you get the application people involved, and you make sure that there's a clear handoff. You don't just like abandon it and just that person, and leave the customer in a lurch. This to me is so basic. Just the fundamentals of good customer service, of basic leadership, and that we're not getting this on the clinical side, because I think you did some research and found some research that this is not a one-off. This is a pervasive issue.
And unfortunately, we just don't know the extent of which, because this could be rolled up into what's considered medical errors, of which there is no standardized classification, no one measuring and no one reporting. So the best estimates are the accidental deaths, which include most of the quote unquote medical error type situations, assuming this could be a medical error. I'm not there yet. I think what I observed was, but we'll see. It's rolled up into that reporting category. I forget the exact numbers, but it's the third leading cause of death behind cancer and heart attacks. I mean, it's so, yeah, it's not a one-off. It's happening everywhere. Look, team-based care huddles are great, but someone's got to lead. Someone's got to take charge. And this whole idea of, we have a hyper specialized medical model where we're not just specialized, we're subspecialized. We're subspecialized to the point that the lenses that the clinicians wear are so narrowly cast, they can't see anything outside of it. So how do you get to this bystander effect, which is the more people that are involved observing a situation means the less likely is someone will step up and take charge. Why? Because they're afraid of getting it wrong. They're afraid of looking bad. It may be a PG2 concerned about a senior resident's reaction to their assessment. No one wants to take the risk. So this rolls up, creates this bystander effect, and the not my patient, not my problem extension is simply this. How is someone not my patient? If they're not on my service, they're not my patient. Well, how are they not on their service? Well, is it a neuro problem? Is it a pulmonary problem? Is it, some other dermatologic problem? You name it, whatever the specialty layer is that could potentially be root in the problem. It's all kind of vague, and unless someone says it's this and we're going in this direction and everyone follows. There are 8 people in the room, 9, 10 people in the room, most of them standing around. The only hands on the patient, the nurses.
Yeah, to me, I don't want to oversimplify, but I really think it's it's a leadership issue. That someone can't identify, oh, there's a bunch of us in the room, we're all shaking our head, yeah, there's a problem here. But leadership says someone takes charge, and it doesn't matter. who it is, as long as there's a person in charge and accountable that then goes behind the scenes and gets the action done. And like the IT example I gave you, and I could give you a lot more where I've been walking around a hospital and someone identifies me because I have a badge, and they're like, "Hey, where is, there's vomit on the floor around the corner." I don't say, "Okay," and keep walking because that's not my issue. No, of course not. I'll take charge. I'll make sure it gets cleaned up. I'll make sure no one like walks through it. I'll wait around, and I've done all that. Or someone trying to find their way around the hospital, or I think all of us and people listening probably think in their minds too of situations where it wasn't their responsibility, but leadership says, "I will take accountability. I'll take action," because it's about service. And in this case, the examples I'm giving are just not life and death, but the one that we're talking about right now is life and death. And so we've got to make change. And that's, again, the reason that we're having this conversation. And Gregg, just for our audience to know, your story and the story of Anthony John Masters is in the white paper of our book that'll be coming out. So the book is written for the public, but this was too important of a story not to be included. And so there's a white paper that's going out to the healthcare industry. And in the white paper, that story is front and center, just to, make sure people understand, our peers, the leadership in hospitals, clinicians understand that this is an issue and it must be corrected and addressed. And like I said, just hate repeating myself, but I'm going to do it, is leadership. And if we don't enforce that as leaders to say, other people, this is how you lead, you're accountable, someone take charge, nothing's going to change.
Totally agree. I mean, it comes from the top. The culture has to be seated top and, top down and bottoms up, and reinforced constantly. And it should be, you see something, say something, risk being wrong, but do something contextually appropriate to what you're seeing, and expect the support of your peers when you maybe veer off track, but do something.
It just makes me mad. Again, I'm really careful not bashing anyone, but if I got an email or text like the ones we're talking about, and all you have to do is say, "Thank you for contacting me. I'm really sorry. That doesn't sound like our normal way of operating. I'm going to get someone right on it." And then as a CEO or whoever, as the head of patient experience, I'll find the right person for you. I'm not going to put it back to you, say, "Well, thanks for contacting me. I'm really sorry. Go take a hike," essentially. It's like, oh, that's just not right. Again, because we're not talking about, did we find the ketchup on aisle 4? We're talking about someone's freaking life.
Right. You would think there'd be more attention and responsiveness to an inquiry of that nature from a leadership perspective.
So we laid out Anthony's story and talk about the importance of leadership and accountability. And really our goal here, again, is not bashing a particular organization or particular people, but it's really about raising awareness, number one. Number two is I'm always a solutions person. I'm always like trying to think, how can we keep this from happening again? And it comes down to just simple leadership. So if there's a last message, Gregg, that you want to leave with our audience, maybe it's, I don't know, call to action, or what can they do to help ensure that Anthony John's experience is the last one of that nature?
Well, that's a tall order, but first of all, thank you for the opportunity to share my story, my son's story, Anthony John Masters' story. I'm really not accusing anything. I'm simply saying that if death is not the outcome that you want, then clearly it's a patient safety and quality of care issue. It should be a never event for a 38-year-old, otherwise healthy male to have a mild trauma brain injury and wind up in the morgue, okay, the day before he was scheduled to, at least projected to step down and leave the hospital. Crashing and burning, dying of a irreversible and permanent brainstem injury, which I believe I observed. So, you know, we all need advocates in this system. And unfortunately, we've co-created a very complex ecosystem that's hard not just to navigate, but to deploy and use in support of whatever care you or your family or friends need. So if you're thinking patient safety, do some research.
Yeah.
I was getting a lot of people saying, get him out of there.
Yeah.
Yeah, there. I said, well, level 1 trauma center, world-class medical school staffing. He's probably in the custody of people who know what to do and take care of him. But just be mindful that there's a complex system out there to navigate, and it doesn't always work at high performance levels. And you sometime may need to get involved, shake the trees, and what is it? Good trouble, as John Lewis would say, you know, do some good trouble. I'm not bashing anybody. I want answers. I want accountability. I want to know why he died, what was done. Was it done appropriately in a timely fashion with the right people making those calls? And if so, hey, I will just deal with the loss, grieve, and accept. But right now, I think there's an opportunity to improve the culture of medicine
Yeah.
to minimize these incidents from ever occurring again. I don't want anyone to be in the horror, to see the horror show that I witnessed the last 48 hours of
Yeah.
Anthony John Masters' life. So thanks again, Ed.
No, that's well summarized, and I appreciate you, Gregg, sharing your story. I know it's still raw. I know it's, I can't
Right.
imagine, so I can't say that I relate, but I feel some of the pain, and it's just not good, and we need to take action. So, for those of our audience, watching, listening, I hope it's informative for you. Take action, no matter what your role is. It's the simple leadership things that we talked about, and to change the culture of medicine. And not my patient, not my problem. Raise awareness, and then just to double down on something you said, Gregg, was on a personal basis. Like, if you ever find yourself in this situation, realize you have choices, and do your research. And that's something else that's in the book that we're writing to the public, is like, hey, public, you have choices, and do research. Don't accept everything that's been told to you. So thanks again.
Can I say one thing, Ed? So the original attraction that I got to this was a roundtable that was moderated by Lisa Rosenbaum, MD, national correspondent for the New England Journal of Medicine, and it's entitled "The Not My Patient, Not My Problem in Medicine." And I read that. It's an audio file, and if you want to learn more, I'll put in a plug for www.endnmp.org, endnmp.org, and that blog post with that audio is embedded there, and you'll learn a lot about the nature of NMP as a culture in medicine.
All right. Well, that wraps up EDTalks. Thanks for listening, and thanks for taking action.